Sorry about that. Can I ask, are we going according to the order that was sent out, Akash? Are we doing that?
Yes, we are. And I think we're about to begin now. So let's do that. So apologies to everyone for a late start, but let's begin. So good evening, everyone, and welcome to what I will say is the most important discussion we can have at this moment in time, because there's a lot happening around us. We have a highly infectious disease, we have vaccines, and we have a population, not just here, but globally, deeply polarized about accepting it. And of course, this comes at a time when the road that hopefully takes us back to some level of normalcy is paved with immunization cards. Now, let's understand what we're dealing with here. As of 4 p.m. today, we have 198,702 people fully vaccinated, with 403,251 people getting their first dose. Now, the government's goal is that at least 70% of the population be vaccinated, with the short-term objective being around 600,000 by the end of September. Now, here's the thing. With the numbers I just mentioned, and with vaccination sites reporting now low daily turnout, there is without question a high level of vaccine hesitancy in this country. And simultaneously, our COVID cases have begun increasing again, with the death rate keeping pace. Now, this is unacceptable. Understand that in a matter of months, we've lost as many people to this disease as compared to 3 years' worth of murders. And I'm seeing a lot of debate going on back and forth between the unvaccinated and the vaccinated. One group is being called a danger to themselves and others. And that group in turn is saying that they're more worried about a negative reaction from the vaccine than a positive PCR test. So again, lots of conversation, but seldom with facts. And I know there are a lot of people who aren't trying to be disruptive or willingly endanger anyone, but there is a genuine thirst for knowledge. Unfortunately, some stopped to quench that thirst in contaminated wells. Thankfully, we have evenings like tonight and the panel before us and the integrity they bring to the discussion. The topic, COVID-19 vaccination. Can it help with non-communicable diseases, comorbidities, and long-haul COVID-19 symptoms? The experts, Professor Terence Simangal, a pulmonologist, that means he specializes in the respiratory system, your trusted television physician, Dr. Joel Tiluxing, Dr. Clifford Thomas to talk about the heart, Dr. Nicole Ramlachan, who will be no stranger to you as well. She is a geneticist, and Dr. Mark West, a cardiothoracic surgeon, and that means he specializes in surgical procedures involving the heart, the lungs, the esophagus, and other organs in the chest. What I'm trying to say is that we are privileged to have them to educate us this evening, and I'm sure they can address some of our burning questions, because it's okay not to know. What's not okay is to be guided by ignorance and hearsay. So let's deal with some facts, people. And let me tell you how this will work. So we have 5 panelists, and they'll each make a 10-minute presentation, and then we take your questions. Put them in the comment box, and the UTT's team will forward them to us. Right. So up first, we have Professor Terence Simangal. He's a pulmonologist, as well as a professor of medicine and dean at UWI's Faculty of Medical Sciences. Professor, you have our full attention.
Good evening, Akash, fellow panelists, and good evening to the viewing audience. Thank you for asking me to have a chat with you all about long COVID. So COVID-19, as most of us will know, is a disease that's caused by a virus, a coronavirus, and it's characterized by a period of acute symptoms. But for some people, there are no symptoms. And in a small number of cases, approximately 1/5, people become ill enough to go into hospital. So while I said that 1/5 is small, the proportion is small, but when you look at a population as a whole, it can be a large number of people. What happens afterwards is referred to, if you have symptoms, as having long-haul COVID or long COVID. And long COVID can manifest itself just as symptoms, or there may be what we call organ-specific manifestations, or even multi-system manifestations. But organ-specific, by that I mean that the disease manifests itself with symptoms and abnormalities in a particular organ. In the case of the pulmonary system or the respiratory system, of course, it's the lung. But you can have symptoms without having abnormalities within the lung. And if you have the symptoms by themselves, we'll just call it long COVID. But if you have abnormalities within the lung, then we refer to the specific abnormalities, such as pulmonary fibrosis or airway disease. And I'll explain those in a minute. But still continuing the overview, if you look at data that's published, you can find a variable proportion. But one very interesting study, which I would really like the audience to pay attention to. This one point I want to tell you. That was published a couple of weeks ago, in which they looked at people who were not admitted to hospital. That's the majority of COVID cases, the 80% that don't get into hospital, including people who had no symptoms. So the definition was that they had this positive PCR. And at 4 months, 1/3, about 30%, had symptoms. And the symptoms could be a wide range of symptoms: shortness of breath, sore throat, cough, and some neurologic symptoms such as loss of taste or loss of smell. If you include in that people who were admitted to hospital, then the proportion of people with symptoms at 3 to 4 months goes up to between 40 and 60%. And the most common symptom for those who have been at hospital is shortness of breath or fatigue. Now, symptoms following a viral infection is nothing strange to us. The symptoms appear to follow what they are found in SARS and MERS, but we know that people who have the flu and who have other viral infections can get symptoms afterwards. For you to classify someone as having long COVID, then the symptoms must be present for more than 4 weeks of the onset of the illness. So a little bit more now about the lungs, because we have experts here who will talk about the diabetes, the metabolic and endocrine system, and of course, cardiovascular, and its effects on preparation for surgery and so on, which of course, Mr. West will do. With regard to the lungs, you may have pulmonary symptoms such as shortness of breath and fatigue, as I said, without necessarily having a problem in the lungs. But if you, a lesser proportion of patients will actually, who have never had lung problems before, will have lung problems. So what are these like? One, you may have airway problems. That is, when a lung function test is done, you may see slow emptying of the lungs, or failure, which we call obstruction, or failure of the lungs to take in much air, which we call restriction. In a small percentage of patients, especially those greater amongst those who are admitted to hospital who've had the pneumonia caused by COVID, but in a smaller proportion of patients, you will see fibrosis in the lungs. If you do a CT scan, you're going to see it's mainly what we call ground glass opacities. So you're going to see some sort of gray shadowing, big gray shadowing like clouds interspersed amongst normal lung tissue. Those are some of the issues. So you ask yourself, how do you prevent long COVID? Because I'm trying to explain to you that even if you're not in hospital, you can have long COVID. So the only way to prevent long COVID is not to get COVID. And that, of course, requires vaccination. Now, there's one other complication that arises. Even if you're oxygenated, so of course, with the fatigue and so on, there'll be exercise limitations. So going up steps, you get short of breath more quickly and so on. But even if your oxygenation is normal during the day, when you sleep at night and your respiratory system relaxes, and you can't take as much air into your lungs as you would if you were awake, your oxygen requirements might be different. And some people actually do require oxygen at night as they sleep. Otherwise, the oxygen falls too low in the blood. So these are some of the complications associated with long COVID and respiratory complications. And as I said, the way to prevent it is to become vaccinated. Thank you very much to the UTT for asking me to present. And of course, I'm available for questions. And I shall revert now to our Master of Ceremonies.
Well, thank you very much, Professor Terence Simongal, saying the only way to prevent long COVID is to not get COVID, and that's why vaccination is important. Thank you very much, sir. Well, from the lungs, we move to the heart. We now welcome Dr. Clifford Thomas, who is an interventional cardiologist at the Premier Healthcare Limited. Doctor?
Good evening, colleagues, and thank you for inviting me to talk on this forum. I'm following on from Professor Simongal, and I'm going to share my screen, if I can get that here. Good. So I'm going to give the cardiovascular perspective, talking about COVID-19 viral infection, comorbidities, the long haul syndrome, and complications. So let's start with what we mean by the term NCDs. NCDs are non-communicable diseases. Now, you may be more susceptible to severe complications of COVID if you have the following NCDs: high blood pressure, diabetes, heart disease, a heart attack or stroke, lung disease, Professor Simongal talked about that, and cancer. These patients are immune suppressed. Other risk factors that put you at risk of severe complications are being older, being significantly overweight, cigarette smoking that already sets up a lung problem, alcohol impairs with your immune system, physical inactivity, and pollution in the air. Here's a chest X-ray of a 72-year-old lady a year ago, and on the left, this is the heart shadow, and you can see the right and left lungs filled with air. They're black. This same lady, after she got COVID, you could see the change in the lungs. The inflammation in the lungs, a form of pneumonia, you could see loss of the black lungs on the left side. And this here is an example of the respiratory problems that occur with COVID. Obviously, as the lungs become packed up with the inflammatory exudate, patients develop shortness of breath, respiratory distress syndrome, and all those other complications. People talk about a storm of inflammation that is released in some patients, and it's due to not just the infection, but an overactive immune response, which plays a role in the disease progression in the very sick COVID patients. The term that you will hear used is called the cytokine storm. Right, so let's talk about the heart. The virus can affect the heart in a number of ways. The virus itself can be toxic to the heart, so the heart can be damaged by the virus. 2, because of the lung problems, you have hypoxemia, so very low oxygen levels cause damage to many tissues, including the heart. There are problems which can occur in clogging up of the arteries of the heart. There is the cytokine storm, which can affect any system, including the heart. And finally, there's a possibility of coagulation just disseminated in all the organs of the body. And what can this lead to? Coronary syndrome. So there are more at risk of developing heart attacks. Damaged hearts from COVID have more chance of having an abnormal rhythm. Direct damage to the heart causes a myocarditis, which can lead to heart failure. And finally, on the cardiovascular system, there's an increased tendency for clotting to occur, which can occur in the veins of the leg and dislodge to the lungs, causing a pulmonary embolus. So that is the problem that we're dealing with in COVID, and that is the morbidity and mortality related to heart disease. There are a number of ways that we have for treating and preventing COVID illness, and that for another forum. But one of the things which we have are the vaccines. The vaccines that are available in Trinidad are the AstraZeneca and then the Sinopharm. Those are the two vaccines which have been available in Trinidad and Tobago. But there are many other vaccines which have been used worldwide: Pfizer, Moderna, some of the other commonly used vaccines. So what's the perception? A lot of people are concerned about the vaccine. Maybe it has side effects, and for various reasons, they are concerned to the extent that they are hesitant or do not use the vaccine. And a survey in Germany looked at some of the reasons that patients said they don't wish to use the vaccine. Number one, they say maybe it might not be safe enough. Maybe you guys haven't really got safety mechanisms down packed. A lot of people think, I'm not too happy about the possible side effects. Some people don't think that the COVID is that dangerous that they need to have a vaccine. Some people just reject vaccines in principle. And interspersed with this, there are some theories and conspiracy theories which make an interesting number of reasons why in Trinidad and Tobago, a significant number of people have not taken the opportunity of being vaccinated. But what is the side effects from vaccines? Well, there are minor side effects of the vaccine, which actually are common. You can have soreness at the injection site, fever can occur, headaches and tiredness. And these side effects can be managed with rest or taking a medicine for fever or pain if it does occur. In fact, the night after the vaccine, I did have a fever and a bit of a headache, and Tylenol relieved the problem within an hour. Now, on the other hand, there is a severe complication of the vaccine. It is rare, and the term is called VITT, which stands for vaccine-induced immune thrombotic thrombocytopenia. What they're saying is that following the vaccine, the immune system was activated that caused thrombosis in blood vessels, whilst at the same time it consumed the platelets, so there was thrombocytopenia. It is rare, but the cases, if they occur within the first month of the vaccine, and the presentation would be things like headaches, severe headaches. The lab test would have to show a platelet count that is low, and some imaging tests, such as a CT scan in the area where you think the thrombosis is occurring. For instance, some of the cases occurred in blood vessels or veins of the brain. So if a person has got really severe headaches with some neurological symptoms, platelet count is low, and the CT scan shows some thrombosis occurring in the veins of the brain, then the diagnosis can be made. there are treatments available for this. So if it is suspected, patients should be in hospital where a protocol for treating that condition would be available. Let's put things in perspective. The AstraZeneca vaccine, which is available in Trinidad, there has been a reported incidence of 4 cases per 1,000 people vaccinated, or 0.0004% of this severe complication after that particular vaccine. Let's go straight to the other end of this slide, and we can see with COVID infection, there is a very high incidence of thrombosis occurring in various organs to the extent of 16.5%. So we are looking to avoid a rare complication that occurs at 0.0004%, where that complications of thrombosis can occur in as much as 16% of patients with COVID. And just to put things in perspective, if you take if a woman uses a birth control pill, there is a risk of thrombosis with that. And a common recreational activity, cigarette smoking, is a much higher risk of thrombosis occurring compared to with the vaccine. So that's just to put things in perspective. Now, one of the questions that people will say is that there may have been people who, after the vaccine, may have died. And the question is, was that death linked to the vaccine? And I'm not a statistician, but let's talk about the denominator we're talking about. Let's just suppose a population has 1 million people. And every year, approximately 2,400 people die from heart disease. That's approximately 200 people per month dying from heart problems. Let's suppose the whole population is vaccinated. Then we already know that 200 people will die each month from heart problems. If 30% of the population is vaccinated, then 60% of patients will die from heart patients in the month after getting the vaccine, but the cause of death is not related to the vaccine. So I'm going to wind off by summarizing that the vaccine is safe. The vaccine has been proven effective in reducing the risk of becoming infected and the likelihood of having a severe illness. It also reduces hospitalization and death rate from COVID-19 disease. The side effects of the vaccine are mostly mild. Full vaccination may require 1 or 2 doses depending on the type of the vaccine. The vaccine does not contain the live virus, and it is not possible to contract COVID-19 from being vaccinated. To be practical, in our medical group, Premier Heart Care, all our staff have been vaccinated. All our doctors, nurses, and staff have been vaccinated. Our immediate families have been vaccinated, and the majority of our heart patients have been vaccinated. There have been no severe complications amongst our staff and patients who have been vaccinated to date, severe. On the other hand, I have unfortunately seen severe complications that occurred in unvaccinated heart patients who got COVID. Thank you. I will return back to the moderator. Thank you very much for having me participate in this session.
Thank you. Thank you very much for the eye-opening visual aid, Dr. Thomas, and thank you for letting us know how toxic COVID-19 can be to the heart and how it could lead to sometimes a higher risk of heart attacks, and also addressing serious concerns about side effects. But bottom line, the vaccine is safe. Thank you, sir. Now it's time to ask the doctor. I'm kidding, but we do have one of the more famous doctors right now in Trinidad and Tobago who is also very well qualified to speak on his topic. Dr. Joel Tiluxing is a consultant physician in endocrinology and diabetes at the Cardiac Specialist Medical Center. Dr. Tiluxing, alive, sir.
Thank you very much, Mr. Chairman, and good evening to all the members of this distinguished panel. It's a pleasure to be a part of it. And indeed, good evening to our viewers and listeners. So I have been asked to speak about the twin pandemics of COVID-19 and diabetes. And I'll share my slides now. For some reason I'm not seeing my view, but I can present this actually at this point. Right, I don't know if you're seeing my screen. Are you seeing a full screen here, Mr. Chairman?
Yeah, we are seeing the outline of the presentation, Doctor.
In the outline, but not a full screen.
You're going to want to hit slideshow and then start slideshow. There we go. We're good to go.
I think we can get going now. So we wanted to speak this evening about the global spread of COVID-19, but there is a twin epidemic, and that is diabetes. And it has been said that perhaps there is a collision and a collusion between these two problems, COVID-19 and diabetes. Now, type 2 diabetes is not a mild disease. Amidst 465 million people, you were speaking about the numbers in the world and locally for COVID-19, but there are 465 million people with diabetes globally. It's the leading cause of blindness among working aged persons, a leading cause for end-stage kidney disease, and the #1 cause for non-traumatic loss of limbs. We have a ward at San Fernando Hospital for foot infections and amputations due to diabetes. You're 2 to 3 times more likely to have a heart attack and stroke if you're a person with diabetes. So it's not a mild problem. And we know that as much as we talk about COVID-19, we talk about global warming, the problems of chronic disease are very frequently driven by increased body weight, the scourge of obesity. We heard from Dr. Thomas about the fact that COVID-19 and diabetes appear to have a collision and a collusion between each other. There is an acute inflammatory response with a host of inflammatory substances called a cytokine storm with COVID-19, and this will damage tissues and organs, the heart, the kidneys, the lungs, and even the brain. These surges in blood sugar, known as hyperglycemia when there is high blood sugar, and it's associated with increased blood clotting and damage to the lining of arteries with scarring to the lungs. Diabetes is similar, collision and a collusion between the two entities. It's a chronic low-grade inflammatory response that slowly damages organs, the eyes, kidneys, nerves, and heart. And of course, the sugar will fluctuate, particularly in the throes of an infection. We've been hearing about, perhaps ad nauseum at these press conferences, about the presence of comorbidities with many of these COVID-19 deaths. Amongst the 1,100 local deaths, hypertension, diabetes, heart disease, chronic lung disease tend to dominate, especially in patients who are unvaccinated. And we continue to see that even as the highly transmissible variants like Delta are on our doorsteps. Now, people with diabetes have an increased risk of infection because of a lower chance of fighting infection, so reduced levels of immunity. That may be linked to high blood sugars, as well as acute or chronic damage to organs. And it's thought that there is an increased risk of severe infection because of these inflammatory substances called cytokines. Perhaps this visual depiction, so those spikes which we all knew would represent SARS-CoV-2, that's the virus involved in COVID-19. So there would be an infection through the nose, the respiratory tract, and there are problems with those soldiers or defenders in a person with diabetes. There are increased receptors that actually accommodate and cause the entry of these viral particles into cells that can be directly toxic to various organs, leading to multi-organ failure and septic shock. And so as a result of this plethora of inflammatory substances, you have something called acute respiratory distress syndrome and end up on a ventilator, and of course, a very high risk for mortality at that point in intensive care. The virus is also thought to be directly toxic to the pancreas. So the pancreas is the factory for insulin. And we know that when we're talking about high blood sugar, it's perhaps a deficiency of insulin, or persons are resistant to circulating levels of insulin. And apart from direct toxic effects to the pancreas, they may actually have clots and scarring called fibrosis at that organ. And there are some reasons as to why blood sugar levels may be high in someone with COVID-19. And that may be linked to problems with diet, perhaps a reduced appetite, reduced physical activity. Some symptoms like vomiting and diarrhea may be affecting food intake. Persons may actually stop conventional treatments, and that also exacerbates fluctuation of blood sugar. Fear, anxiety, and tension also worsen blood sugar control. We spoke about a host of inflammatory substances that lead to the cytokine storm, and persons admitted in a critical state, if you're short of breath and you're admitted to hospital, are frequently prescribed steroids because these have been found in many trials to reduce the chance for death and even progression to a ventilator. So the use of steroids, though unfortunately those are double-edged swords in that they may raise blood sugar levels. So if you're a bit squeamish, avert your eyes at this point, because we saw there was a problem called mucomycosis in India following the catastrophic rise in infections there, linked to high blood sugars, the use of steroids, and a superimposed fungal infection that damaged the ears, nose, and throat, the eyes, and even the brain. The problems of diabetes, high blood pressure, and high blood cholesterol tend to be linked, as we mentioned, to increased body weight. So it's simple as you think about increased weight or the scourge of obesity as being the driver. You look in the rearview mirror and you're seeing the other parts of the metabolic syndrome there. And we're seeing it especially now in a younger population. It was thought that type 2 diabetes was an illness of older persons, but we're seeing it now for different reasons, as children have been exposed to a virtual learning environment, and one that is more sedentary. And this has led to increased body weight and an increased chance for type 2 diabetes in school-aged children. This slide just shows that there are some changes that should be made in the management of not just diabetes with COVID-19 or in the era of COVID-19, but perhaps in all chronic disease. Telemedicine for most of the consults can be done in a remote environment. It's an imperfect substitute for the in-person clinical encounter, as there may still be a need for face-to-face podiatry, so that's foot care or eye care, and high-risk pregnancies. And of course, when we're thinking about teaching blood sugar monitoring, perhaps the administration of insulin, and of course, blood tests may require action. And it's time that we acknowledge and strengthen the role for primary care in the management of these chronic illnesses, particularly amidst waves of COVID-19 infection. So some general principles there would be to monitor the local situation and be aware of emergency numbers, ensuring that there is access to essentials like food, water, and medicine, and talking to your doctor about managing all chronic medical conditions. We've forgotten this during the throes of COVID-19, and keeping the best possible health. We're talking about the rising frequency of obesity and all of the complications that tend to come with it. But diet and exercise remain essential pillars in these lifestyle diseases. Make plans to be able to look after a sick household member and get the vaccine. As mentioned before, diabetes and all these chronic diseases, have a chat with your doctor if you're uncertain, but they reduce the chance for severe infection, hospitalization, and death. And avoid the 3 C's, those closed, crowded, and close contact settings in which there is a greater risk for transmission of SARS-CoV-2. And we talk about all the mitigation strategies, social distancing, high quality masks. So there is a need to emphasize that all masks are not the same, although the law would not distinguish amongst them. High quality masks like N95 or double masking with a cloth and surgical mask would be better, particularly in those high risk environments in which the transmission is more likely to occur. So I briefly alluded to the fact that psychological problems also impact on blood sugar and indeed on all chronic diseases. Patients with diabetes, perhaps about 30 to 40%, are more likely to be depressed and anxious. And this has been exacerbated in the COVID-19 pandemic. Taking breaks from listening to, watching, or reading about COVID-19. Focus on the facts with respect to the illness and the risks to you and loved ones. Find some time for relaxation. Some persons may like music, meditation, physical activity, whether you're running, walking, biking, Zumbaing somewhere, and prayer may assist. Connect with friends and family. And if stress continues to affect your lifestyle or your life, please seek help. So we're talking about lifestyle changes, and you want to focus on the good habits: fruits, vegetables, nuts, peas and beans, low fat and low salt, stopping smoking, and avoiding the bad ones. So I just thought I'd put a bit of a local flavor there for viewers. And physical activity. So we salute and applaud our sisters from Jamaica for being first, second, and third at the Olympic Games ongoing in Tokyo. And a reminder that we too can be number one, as Hazley Crawford ran to a gold medal in the 1976 Montreal Olympics. And we remember Mr. Keyshawn Walcott for his gold medal javelin throw in 2012. And it's important, I thought that Hazley Crawford would be one of our national icons that I wanted to highlight here on a talk on diabetes and hypertension, as he subsequently became a spokesman to prevent chronic diseases as he shared his battles with high blood sugar. And the value of exercise, perhaps 30 minutes for most days in the week. Check with your doctor before embarking on any program. So this gentleman here is walking his dog for some sort of exercise. So at least he's fighting obesity in the pet population. And embrace the vaccination, man or woman in this case, as there is a reduction in all these chronic diseases for severe infection, hospitalization, and death. And perhaps it would be a poignant reminder from Julius Caesar that men at some time are masters of their fate. The fault, dear Brutus, is not in our stars, but in ourselves, for we are underlings. And the fault would certainly rest in ourselves if we do not afford ourselves an opportunity to be vaccinated against the scourge of COVID-19. Thank you very much. I hand you back to our chairman.
Always relatable. Thank you, doctor. And we all know in this country that diabetes and obesity are not foreign to us at all. COVID or no COVID, keeping as fit as possible is of paramount importance. I, of course, particularly like the advice on mental health. Well, viewers, I told you that this would be worth your time, and we're not done yet. Dr. Mark West is a cardiothoracic surgeon and a consultant at the Eric Williams Medical Sciences Complex, or what we commonly refer to as Mount Hope Hospital. Dr. West, we are eager to hear your presentation, sir.
Good evening, Akash. Thank you very much, fellow panelists and the viewing audience. The thrust of the discussion today is actually on vaccination and COVID-19. Can it help with NCD's comorbidities and long-haul COVID symptoms? And you've heard my illustrious colleagues speak extensively on this, and I have one more to follow me. So I'm sort of like the meat between the sandwich. However, I would like to touch on certain areas of surgery, but I really, really want to drive home the important message about vaccinations. You'll hear it again in my talk, but vaccination really is the key to getting us out of this serious situation that the country finds itself in. And if we do not vaccinate, for those who do not vaccinate, for those who will not vaccinate, they or you will become the reservoir of COVID-19 and continue the issues and problems, which is a dehumanizing effect on Trinidad and Tobago, with all the problems that we've seen and continue to see, and all the closures. The government has got behind it, the opposition, the religious, everybody is shouting, vaccinate. And it's for a very good reason. It is the key. It is the key. Without the vaccination and the increase in numbers, we are in for a terrible, terrible time. So I'll just start my presentation now. So thank you again. Trinidad and Tobago is in a race to vaccinate as many people as possible before the onset of the Delta variant. We need to be cognizant of what is happening around the world and in the bigger countries, where we have seen that they have contained the COVID virus and COVID-19 up until now, and then the Delta variant has come along. And what we are seeing is a re-expansion of their numbers spiking. So we are back where it all started. We must vaccinate. Please get vaccinated if you have not already done so. The key to ending the infections, deaths, and unnecessary anti-human practices that we have all experienced is to vaccinate. No one person can do this alone. We, as part of the medical fraternity, the administrative, the politicians, we are all on one team. It is to succeed and success and enjoy our lives as we used to. But if we fall and do not vaccinate, we will pay a heavy price. Where are we now? Well, The COVID vaccine pandemic was declared in March 2020, a little over a year and a half ago. It is probably the greatest health challenge of our century. Total number of cases are roughly 200 million, and there are about 42 million people who have died, unfortunately. Where are we in Trinidad and Tobago? Well, we had 32,000. Who would have thought, 305 when it all started, that we would have such a bad effect? Tobago, as we know, is getting heavy numbers. Trinidad and Tobago's numbers have come down, thank goodness, but it will increase again if we are not vaccinated. Dr. Ramlachan Singh, I'm sure, will give us the number and percentage of where we are at the moment, but it is not where we need to be. And unfortunately, God rest them, 1,101 people have lost their lives, including some of my fellow medical colleagues, and I will speak about them in a while. Just to put it into perspective, the last pandemic, the true pandemic, was the Spanish flu. And at that time, and it's estimated, over a 2-year period, 500 million cases. We are already at 200 million. So if this continues, we might catch them, which was a shocking thing because they didn't have the vaccines. And their deaths were 17 to 100 million. It's very estimated there as to where the numbers of that died. There are some serious differences though. We have vaccines. Theirs was an influenza. They didn't have the vaccines. They didn't know. We have treatment protocols. We have medications, including steroids, antivirals. We have an intensive care unit, and we are very blessed to have in our parallel system, a separate hospitals actually separated to treat these patients in Trinidad and Tobago. Other countries do not have that. But as you heard the ministry officials saying, we came very close to being overwhelmed. If the Delta variant continues and expands without vaccination, we will be overwhelmed without oxygen. We now also have a greater understanding of the vaccines and the virology and how everything works. So in general, we can look upon surgery as part of the bigger health system. There are about 12 systems: medicine, we've heard our colleagues speak, surgery and anesthesia, psychiatry, all have a role. We know about some of the mental health challenges that this has brought on, and we will be hearing further. Pediatrics and long haul, and for the children, obstetrics and gynecology. And then we have family practice as well. And of course, we have the non-clinical sciences, radiology, pathology, immunology, microbiology, and medical law all play a part. In surgery, there are about 12 specialties, and they all have been affected. At Eric Williams, where I practice, we are fortunate in that we have all the specialties on site. We're the only one, probably in the Caribbean, that has this level of tertiary care. However, we have been severely affected by the COVID. What has happened? Well, we have seen a total reduction in the amount of surgeries being performed. We have converted mainly to emergency and urgent cases. Emergency cases, obviously, are those that require immediate treatment. Trauma cases, unfortunately, in Trinidad and Tobago, we have a propensity to shoot and stab one another, but there are also surgical emergencies which require immediate surgery. My colleagues have been busy doing that. We have urgent cases for which we cannot defer the cases, such as cancer cases, for which if we do not operate, the patients will succumb. As a consequence, we have almost no elective cases up and down the country. I did a phone survey of my colleagues, and this is the case. We have reduced staffing levels in the surgical suites because of the reduced nursing care. The nurses have been seconded into the parallel system, and therefore it has impacted the number of nurses available both in the general hospitals and in the theaters. Our anesthetic colleagues have also been seconded to assist in the various in the parallel health system, and this has also impacted the amount of cases we have done. And we also know that in certain of the hospitals, some of the wards have been used for COVID patients, not extensively, because most of it is in the parallel health system, but in a few hospitals, this has also caused reduced capacity and also impacted so that we are reduced significantly the amount of operating. What does this mean? It means that many of our fellow citizens who require surgical care are holding on, as it were. So the COVID-19 has had a major effect on our population and forced many of our population to be waiting until we can get back. Can I just remind everybody, we will not get back unless we can vaccinate. What is the effect of COVID-19 on the surgical patient? We know from studies done that patients who are operated on with COVID-19 have increased risks of death. They have increased risk of becoming unwell. This is mainly in their airway system, particularly cases involving the thoracic surgery where I practice, because COVID does primarily affect the lungs. In addition to this, when we bring patients to surgery, we must insist that they are COVID negative. That is done through PCR testing and antigen testing. Most of the places require a negative PCR within 72 hours. However, with the organizational situation, sometimes while we do have the negative PCR, we do not get an opportunity to get into surgery, and then we have to repeat the process. So it is complicated in getting the timing and the surgical slots aligned. As a result, the efficiency goes down. And as a consequence, patients, even the urgent ones, have to hold on while we repeat the PCR. Certain hospitals have testing machinery such as Gene Expert, etc., which can fast track this, but not all hospitals. Eric Williams has this, but not all the other ones have it. And as a consequence, it can take as long as sometimes a week to get the PCR back. This, of course, impacts the whole surgery, and therefore the whole process starts again. When it comes to the effect on the patient, my colleague, Professor Simongal, mentioned the lungs, as did some of my other colleagues. This is what thoracic surgeons may be faced with. You can see here a chest X-ray showing where the arrow is, that lung has actually collapsed. The white areas represent tissue which is overexflated because there's air. This is called a pneumothorax with surgical emphysema. There's air trapping under the skin. Why is there so much air? Because the lungs are leaking air because of the COVID infection. The lungs can no longer control the amount of air within themselves, and they leak out. Now, the lungs then collapse, and it can cause severe respiratory compromise to the patient. And sometimes the patients have to be intubated and ventilated. This is a CT scan showing a similar process. And again, we can see that there's air in the wrong places. And this is, as I said before, an effect of COVID. In the lower aspects, we can see, here we can see where the lung has now developing consolidation and a certain level of ground glass with fluid. I've put this up here to show the viewing population that this is a very real problem. Myself and my colleagues, Mr. Ian Ramnarine, Dr. Shrikant Sagubadi, Dr. Ivan Gamboa, thoracic surgeons with myself, and we work assiduously with the Covet Hospital where we deal with these problems on a regular basis. And this is what you may end up with if you do not get vaccinated. There was a paper produced recently from Birmingham looking at the mortality rates if we operate for patients who have COVID. And what we see at a glance is that the longer you can delay surgery from patients who presented with COVID, the better the survival. So 9.1% mortality within 2 weeks of diagnosis. And you can see it comes down to 6.9 within 3 weeks, 5.5 after 5 to 6 weeks, and down to 2.0 for surgery at 7 weeks or more post-diagnosis. What are the effects on the staff? Well, there are operating on patients who have COVID, particularly patients who, surgeons like myself in thoracic surgery on the airways or anesthesia, there is an increased risk of transmission and infection. And there, of course, is increased risk of death. Unfortunately, this point is hardly driven home by several people who have died. We have Dr. Al-Hawani, who was a couple of years behind me in medical school. He was an ENT surgeon, he died. We had Dr. Li Wenliang, 33-year-old, who was one of the first doctors to mention and complain about the COVID. It brought it to the attention, he was ignored. Unfortunately, he died. We have our local doctor, Dr. Dhiran Mahabir. He was an A&E consultant at San Fernando General Hospital. He died. Dr. Shivral Sunarayan, working at A&E, he died from COVID. And the bit of good news is my colleague, Mr. Ian Ramnarayan, he had COVID, but he survived and he's still practicing and very well. The point I'm trying to make here is that we, the staff, are at increased risk, real risks of dealing with patients who have COVID. And of course, the key to not getting COVID is to vaccinate. So surgery, essential surgery takes place irrespective of the vaccination status. If we have a patient who we feel, who in any way we do not know, we put on what we call our personal protection or PPE, and we will operate on them. The Royal College of Surgeons in England say that one must separate surgery by at least 1 week if you've had vaccinating, either before vaccinating or after. That is, if you've had your vaccination, you should wait at least 1 week. Between 1 and 2 is actually it's the range before you have your surgery. And on the other side, if you have had surgery, you should wait at least 1 to 2 weeks before you have your vaccination. This is a general statement, and it really depends on the type of surgery. People who have had heart surgery, their whole physiological mechanism is disrupted, and they may require a longer period of time before they vaccinate, as well as people who have cancers. So to find out exactly what you should do, you should consult with your local doctor and specialist. What is the future for surgery and managing COVID? Well, unfortunately, COVID-19 will be with humans for quite some time. Vaccination is the key to the normalization of life. And in Trinidad and Tobago, we are urgently looking for that, but we must rigidly and try to vaccinate. There are on the horizons better ways to vaccinate other than by injection. They have not been fully tried. Hoping that Dr. Ramlachan can speak about them. It's very exciting to see what is coming. There are also going to be better ways to test, faster ways, so that we will be able to get the results quickly. And of course, better ways to treat. We do have a host of treatments which has improved survival, but there are new medications coming along. There's also improved vaccine and virus sensitization. We expect to have probably COVID vaccination passports. We already know it's there for travel, and we may well need it for normal living. That is, when you move about, you may have to prove that you've been vaccinated to enter certain places. We are seeing this already in other countries. It may come here, and so we should be prepared. Why? Because the effects of COVID-19 are so severe, and COVID-19 is a very transmissible problem. So what are my key takeaway messages? Please, if you haven't realized it, vaccinate. You must, the government is trying its very best. As I said, we are in a race to get vaccinated. There are mass vaccination sites up and down the country now, as well as health centers. Please vaccinate. Remember the 3 W's: wear your mask, watch your distance, and wash your hands. This is a very, very serious problem we're facing. We do have a silver lining. We do have a potential way out of it, but we, the country, will not get out if we have people who will not vaccinate, who refuse, because they will become the reservoirs of COVID and Delta and everything else that comes along. The country needs you who are not vaccinated to get vaccinated. Thank you very much.
Thank you very much, Dr. West. You started and you concluded with a very robust statement that I'd like to repeat. Vaccination is the key to us getting out of this. And for those who do not vaccinate, you will become the reservoirs of COVID-19. Thank you, Dr. West. Also, I see we have a couple hundred people viewing us live right now. That's really good. A special good evening to you all. Don't forget, after our last speaker, we will be fielding your questions. Put them in the comment section below. You can even direct one to a specific panelist. Now, our last contributor, you'd also know from your television screens for quite some time. We trust her in the media, and that's because Dr. Nicole Ramlachan is one of the quintessential experts in matters COVID-19. She is an associate professor in biotechnology at the University of Trinidad and Tobago and a consultant geneticist at Genex Diagnostics Limited. What do you have for us, Doctor?
I'm going to share my screen right now, so we'll get right into it. I know everybody's been listening to all our experts, and thank you so much for joining us. And I would like to say, thanks to the expertise of our esteemed panels to be able to put everything into perspective, because it's one thing where I appear and I'm, little lowly me with no clinical background. And, these guys are there to say, well, look, this is what's happening they're in the front lines. They're taking the hits for people who are unvaccinated. And that's what we need to realize. This is a real scenario, and we have to be responsible. And we have to be responsible for those who are, like our expert panel, who are in the front line and actually working with patients on a day-to-day basis. Just wanted to say this is the first in a series of 4 panels that we're doing, where we're actually talking about the comorbidities and exactly what happens with these kinds of patients in terms of that. And we've heard from all our panelists, and I'm kind of going to give a perspective. And I always have to give the genetics standpoint and the immunogeneticist standpoint, because that's my view, and answer those questions exactly about, what vaccines do we have? Where did this virus come from? Those are the kinds of things. There's a lot of misinformation around, and I always try to start with the beginning of the story. As boring it might be for some of you who've heard this multiple times, we have to go through it, because it combats a lot of the misinformation and the stuff that's out there and circulating, and doesn't seem to die, even though it's not based in fact and reality at all. So let's start with, where did SARS-CoV-2 come from? Well, most likely it came from mutations that were accumulated in the previous host of the SARS-CoV-2. Now, we've seen this before. We've seen zoonotic diseases jumping from animal hosts into human hosts all the time through history. Spanish flu was probably one. Bubonic plague, way back in the day, was one. More recently, in modern times, we had SARS, the original SARS, in 2013-14. We've had Ebola in 2016-18. Previous to that, we had all the bird flus, Asian flu, swine flu, literally jumping from an animal host to a human host. Why? Because of wildlife trafficking, habitat destruction, climate change. They're coming more and more closer in contact with humans, that now where they recognize that, oh, this might be a good host. Of course, they're not actually literally doing that, but that's really what happens evolutionarily. They get pushed in an evolutionary direction to mutate, to be able to get into those new hosts. And that's what happened with SARS-CoV-2. The spike protein, which are these little black things on the surface of the cell, mutated to attach onto the ACE2 receptors of the lungs. Now, you heard from Professor Simangal and some of the other panelists about the lung issue and how it actually gets into the lungs. When that attachment happens, it's like a lock and key mechanism, and it's a specialty thing that just randomly accumulates, again, the mutations. And it gets into the lung cell, pretty much harnesses that lung cell as a virus manufacturing plant, produces multiple copies that come out and then go on to cause all the other things that we also talked about, the cytokine storm and all the infections of all the other organs, and big problems that might eventually lead to severe disease, hospitalization, severe disease, maybe intubation, maybe dialysis, and then possibly death. If you are able to recover, sometimes you have the long haul COVID symptoms that we also talked about. But this is basically the scenario. What has happened with the mutants and the mutations is that they seem to collect a lot in the spike protein, because that is really what is going out there and actually attaching to these cells. And we're seeing the variants that are common now, the Delta, the Epsilon, able to, and the Gamma, able to infect younger children and youth, because now they're mutating to be actually have a more severe, secure attachment, and they're more transmissible because of that. And that's really what we want to prevent. If we are vaccinated, this doesn't happen. These viruses don't circulate in the unvaccinated population. They cannot accumulate these mutations to evade immunity and all of that. So that's one of the reasons why we keep saying vaccinate, 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 because we don't want this continued mutation path to occur. What happens with the chain infection? Of course, the reservoir we talked to about in terms of how it jumps into the host. How it gets out of the host is important too. This here, mucous membranes, mouth and nose, how it transmitted person to person, airborne, it stays airborne up to 6 to 8 hours bound to air particles, how it comes back out again, mucous membrane, and then this here, the susceptible host. If the host is not susceptible, if you've been fully vaccinated, very, very rarely do you see the virus having the ability to replicate in that host. The host might still be infected, yes, but it's not going to have that replication cycle that we see, accumulation of mutations and big problems, right? How do we know somebody is positive? We have to test them. We have the antibody test, which is a serological test. It is usually most useful post 7 days to be able to determine if you've ever had an infection, especially for people who are asymptomatic. Also important prior to vaccination, because if you've been asymptomatic and you vaccinate too close to your infection, sometimes there are issues with increasing adverse effects and so on. So that's an important test to actually do pre-vaccination as well. The RT-PCR test is very sensitive. It detects actually single molecules of virus, right? This is what's required generally for travel, employers, for employees to return back to work, those kinds of things. Antigen test, very useful as well, very quick. The RT-PCR test takes about 12 hours to 24 hours, antigen test 20 minutes. And it's cheaper. Again, it tests for hundreds of particles as opposed to single particles in the case of the RT-PCR. So a little less sensitive, but still very useful. And usually this is useful after from the first day of symptoms up until about the 14th day. The RT-PCR can actually be used even prior to symptoms when you're still asymptomatic or before your symptoms actually appear. When and where should you test? Very important. When you have symptoms, if you've been exposed, if somebody that you know in your house has been exposed, if you've been requested by your employer to go back out to work or for surgical procedures in the hospital, as Dr. West alluded to, if you have concerns and you want to know your risk. Dr. Thomas mentioned the clotting disorders. We also have genetic tests that we can actually do to determine whether or not you have a hereditary risk or a personal risk of having clotting disorders, thrombophilias and all of those kinds of things as well too, as well as if you are at risk for severe disease for COVID and possible death. So these are things that you can be tested for. What has been happening actually right now in the world in terms of new cases per million is that they've had a spike in the last couple of months. Trinidad, of course, spiked up, late May, early June. We came down and now we're actually increasing quite a little. If you look at the numbers, we're actually going up a little bit. And United Kingdom had a huge spike most recently. France is on the way up. United States slightly up. Argentina had a big spike and they're coming down, as is Colombia. Guyana, Barbados, India, Germany, and Canada is kind of steady. But with the arrival of the Delta, we're actually seeing increases in number of cases. But look at how this has translated to deaths. I want people to be very aware of this. In Trinidad and Tobago, we actually had way more deaths at our highest peak than India did. And this is very shocking to people because we are comparing deaths per million people. So that's the rolling 7-day average, not total numbers, because that's not how you're able to compare apples to apples. We had to compare the rolling 7-day average. And look at that, we were at one point in time 11.48, higher than Argentina, higher than some of the other countries that we're seeing, and much higher than India and the US. Now we are decreasing, but we are still right at about, as of yesterday, 5.41. Colombia is dropped down to 4.87. United States and of course United Kingdom, France, Venezuela, Maldives, India, Germany, Canada, that all had increasing cases, are all almost down to nil when it comes to death. And that is because of the difference in the vaccination rates. And that is something very important people need to know and people need to acknowledge. The higher the vaccination, the lower the risk of severe disease and death. And the deaths actually drop almost twofold for every 20% in vaccination. So that's something that we have to consider moving forward. Who is at risk? We discussed this, my esteemed colleagues mentioned all of these comorbidities, together as a unit. There are quite a few, even some that we don't consider, like irritable bowel disorder was actually noted as a comorbidity that increased COVID-19 risk in veterans in a veteran study. So it's very obvious to all of us who are involved in this that severe COVID-19 infection occurs in individuals who have a lot of these kinds of associated disorders and disease. And in fact, hospitalizations were almost 6 times higher and deaths 12 times higher for COVID-19 patients that had cardiovascular disease, diabetes, and chronic lung disease, which are the big 3. In terms of hypertension, about 2 to 3 times likely to be seriously ill, and cancer at about 76% more likely, which is quite a lot, and 3 times more likely to die. And chronic respiratory disease upwards of 4 times more likely to be hospitalized and die. So this is very, very serious. In terms of the COVID long haulers, they are actually at greater risk of developing fatal illnesses months later. This is a very critical situation that we're seeing all around the world. Some of them have had these symptoms in excess of 18 months, a very serious situation that seems to be progressing. In terms of what has happened just before the pandemic, I wanted to show you this because I thought this was interesting. This is the top 10 threats to global health in 2019, according to the WHO. And if you notice, vaccine hesitancy is one of the biggest ones. It actually it superseded Ebola and the high threat pathogens, of which a coronavirus was one. So they actually had calculated the risk and said, okay, well, vaccine hesitancy, just from the known viruses and bacterial illnesses at the time that were vaccine preventable, was one of the big problems that we were seeing in trying to control outbreaks and global health issues around the world. Now, if we looked at this, I thought this was interesting because this is a percentage of US adults who was surveyed up until May 2021 that said, okay, if it is the COVID-19 vaccine was FDA approved, will you get it? Now, if you notice over here, it didn't matter what months they asked them. They all are basically around 13%. What does that tell you? That tells you that this is a group of people who are not going to get vaccinated or do not want to get vaccinated, regardless of what. Right at around 8 to 7%, I was saying only if required. And then if you notice, early on, the wait and sees were very high. And as time progressed, and information became more available, those numbers dropped all the way down from 39, almost 40%, all the way down to 12%. And the as soon as possible, of course, really came out to the game, because if you notice, the ones that were already vaccinated started right around the same time and around March. And by May 2021, they had upwards of 62% already vaccinated. So these are the people that we talk to. These are the people that we convince. These are the people who want the vaccine. These guys here, this 13%, we can live with that. But the point is that we have to get our population upwards of 60 to 70% in taking these vaccines in order to be able to move forward. What has happened over time? When we started this process, when I started this series back in April, we had only 1 billion people vaccinated. 3 months later, well, a little less than 3 months later, guess what? Almost 4.25 billion people have been vaccinated as of today's date. So that's fantastic. The rate at which these vaccinations are coming in, the rate at which we're getting information, the rate at which the vaccines were made available is never before seen in the history of mankind. And we need to recognize that. And that is basically because of these kinds of technologies. The mRNA vaccines, the Pfizer's and the Moderna, fantastic technologies, been around for about 15, 20 years. This is not brand new. I need to stress that 100,000 times. What was happening was that the vaccines that they were producing weren't packaged properly. They didn't have a lot of success in what they were using to package it. And before coronavirus, just before, when they pushed a whole bunch of money of it, they tested a lot of these vessels and they came up with this lipid nanoparticle idea. So what happens is it's literally a fat molecule. That's the reason why we have to keep this at -17, -20, because it melts at room temperature very, very quickly. Developed as a vaccine, literally enters the cell, promotes the mRNA spike protein. Well, it codes for the mRNA spike protein that we just talked about. And the cell then produces antibodies against that spike protein that comes out of the cell. Fantastic model, very, very good success. Both the Pfizer, BioNTech, and Moderna, and a couple other versions that are coming out of Canada have been very, very successful, right? And the good thing about this is a clean vaccine, no adjuvants, no problems, very little issue with what happens when it gets into the body. The adenoviral vector vaccine is very similar in terms of the mRNA, except they package it in a vector. That gives it a little extra boost. So your body gets a little more angry and produces more antibodies and says, yeah, you know what? When I see this bad spike protein, I'm going to get it next time. And again, it comes through the mRNA of the spike protein, but it gets into the ribosomal area of the cell. You notice none of this is going anywhere near the nucleus where there's DNA. Nobody's mixing mRNA or DNA. Cannot happen in the cell. First of all, it can't happen, period. But it's not even physically going near the nucleus, right? So I just want to put that particular argument to rest as well too. In terms of the Sinopharm, that's old school. This technology has been around for 200 years. This is from smallpox, where we take the whole virus, kill it, attenuate it in some way, change it so that it's no longer infective, stick it back into the body with an adjuvant to cause issues so that the body gets angry again and starts to react against it. And the antibodies are produced against the whole virus, right? Very old school. There's nothing new about this at all. So for people who say that this is new technology and I don't want it, you should embrace the Sinopharm, Sinovac, Sputnik 5. Of course, the ones that we have in Trinidad that are WHO approved, right now the Sinopharm, no issue with how it enters into the body and how it produces that immune response. There are some things that are being developed. Dr. West alluded to it, one of which is a nasal spray DNA vaccine coming out of Canada. And there are a couple more companies that are actually coming out with this. The idea is that it doesn't have to be injected. Again, same concept. Instead of the RNA of the spike protein, they're using the DNA, gets into the cell, spike protein comes out, makes the body angry to produce antibodies, and you get a long-lasting immune response, but no needles. So people are very excited about that. Not come out in phase 3 trials yet. Protein subunit vaccines, this is like the Novavax, and some of the other ones, they're actually using intermediate models that are not animal models to grow it up and be able to add it into the vaccine. And again, they're getting good results, sometimes 92% in terms of efficacy, but again, they're still in phase 3 trials. And we also have virus-like particles. This company out of Canada is producing this in plants, which is exciting because they don't use an animal model or use an animal cell model. Makes it cheaper, makes it easier. And again, you're getting the immune response in the whole viral protein as opposed to parts of it. So that's just some of the options that we have that are coming on stream later on. What we have right now in circulation, the WHO, this is the most important line here, 100%, almost 100% of efficacy against hospitalization and death. And that's what we want to see. Nobody's saying that 70% and 66% and 95% is perfect in terms of disease prevention and infection, but this is what we really wanted to see, and this is what the scientists consider to be a success. It's being used, all of these vaccines are being used all around the world. The most used, of course, is the Oxford AstraZeneca, over 181 countries, and the Pfizer, BioNTech in about 111, Sinopharm in about 64, Moderna in about 64, the Gamaleya Sputnik in about 50, Sinovac in about 38, the Johnson & Johnson in 37. And then we also have the Abdala and the Subunit being used and tested in Cuba. Now, what is the concise guide for vaccination if it is that you have one of these chronic diseases? Vaccinate. The studies have come out, all of these people have been included in the initial clinical trials, phase 1, phase 2, phase 3, where there's no contraindications with people with stable clinical conditions. You can seek your doctor's advice, but generally, everyone is being advised to take COVID-19 vaccination, as all of these experts have discussed in their different presentations. If you have any of these chronic conditions, and of course, individuals need to continue their medication. That's something that's also of concern with some people. If you are stable, you should get vaccinated for anything that's here on this side, if you notice. Cancer, of course, they usually ask you if you're in remission or you're between chemotherapy treatments to get vaccinated at that time. But generally, no issues with the exception of acute myocardial infarction and acute stroke. You're asked to wait 3 to 6 months for vaccination. And of course, if you have any clotting disorders or risks of clotting disorders, you're asked to test beforehand. In terms of variants, they've renamed them now, and I want to call them by their correct names, the alpha, beta, gamma, delta. The delta is the big one that we're concerned about now, and these are variants of concern. Why are they concerning? Because they can increase in transmissibility, they can cause changes in virulence, they can cause issues in surveillance where we can't find them, and the vaccines won't work against them, therapeutics won't work with them. And unfortunately, we're seeing that with Delta. We're actually seeing breakthrough cases with people who've been vaccinated. Of course, they're not dying, but we're actually seeing that, and we are seeing more infectivity in younger children and youth, because these variants are moving away from the original form, which is what we don't want to see. The vaccines are effective. The WHO have been testing them quite effectively and asking countries to test them based on their particular strain that's available and their variant that's available. The Epsilon is one that we actually did some work in with looking at the mutations, and it actually shows that it evades neutralizing antibodies. So this is one that's worrying, that's on the uprise right now, that's now been assessed to be a variant of concern. And I wanted to show you this in terms of, I'm always interested in the genetics and the mutations, and it's actually showing where you see the X, that is where the antibody would have bound to the original form of the virus. And now there's no longer a place for that antibody to bind because of the mutations that are accumulating in this particular variant. In this case, this is the Epsilon. So this just came out in Science a couple of weeks ago. Just to let you know, it's actually a physical thing that's blocking the ability of the antibody to bind to the virus, right? The Delta has been on the rise. Look at these. This is July 9th. It's coming down now in United Kingdom and Spain and Portugal, but still on the rise in some of the other European countries. On the rise in the US and this part of the world, as well as in Indonesia. In particular, this case in Florida, they're saying 12,408 people are now hospitalized with COVID in Florida, setting a new record. 1 in every 1,750 residents in a bed right now. So it's big trouble. And they're calling it a pandemic of the unvaccinated. Are the vaccines effective against the variants? Yes. More and more research comes out. As I mentioned, we have 4.25 billion vaccines in arms. What that means is that we have data. We have data coming through the Wahoo, right? And what does it show? It shows that, yes, Pfizer in particular, AstraZeneca, Sinopharm, all show good efficacy against the Delta in particular, the Novavax against the Gamma, some of the other ones, AstraZeneca and so on, against the Gamma as well. So we're getting good data, and it's showing that the vaccines we have are going to work against the variants. Are there adverse side effects? Yes. We mentioned some of them. The blood clotting with the AstraZeneca, the vessel leaks with the Johnson & Johnson, Guillain-Barré, with the Pfizer and Moderna, we have the blood clotting as well as the myocarditis. We also have encephalitis with the Sinopharm Sinovac. There's always going to be risks with whatever you take and you introduce into your body that might actually cause an issue. That always happens. But the problem is that you need to understand you can't equate risk with the need to take it. For example, the myocarditis, a lot of the conditions that they're seeing are mild, and the doctors are saying that the benefits outweigh the risk, specifically with that. Same thing with the blood clotting factors that we talked about earlier, is that the risk is 1 in a million with Johnson & Johnson, 4 and 5 in a million with Pfizer and Moderna, and 4 in a million with AstraZeneca of having a blood clot. But it's way much higher, 16.5% with COVID-19 natural infection. And of course, it's higher with natural smoking, your natural risk with smoking and using birth control and those kinds of things as well. Of course, there's a lot of issues with AstraZeneca, with uptake of AstraZeneca and people being blocked from traveling. Lots of issues are coming out all over the world because they have their own recommendations, but we're used to that. That is not new. You cannot go a lot of countries around the Caribbean and Africa without a yellow fever vaccine. You have to have it in order to enter the country, in order to work in the country. So vaccine mandates are not something that is new to us as a society. We all have to vaccinate our children with the 6 main vaccines for pre-treatable diseases prior to entry into high school and university and even kindergarten. So this is not something that's new. So we have to just work with the countries that are advising this. And why? Because look what's happening with Japan. Japan had very strict restrictions on their entry, treatment, testing, and yet still they had big issues with the peaking of cases, right? Ontario had a big peak happening early on in the year, but their vaccination was so high, 70%, they got those numbers down pretty fast. So where vaccination increases, we see a direct response with cases decreasing. The vaccine improves the symptoms of the long haulers, that's known. A lot of people actually have reduction in symptoms. Even though we might have breakthrough cases, somehow they're much lower, right? So we've had 5,000 out of 78 million people with breakthrough cases. It's a little bit higher with the Delta. However, the people don't have severe disease and death, as we mentioned. How has Trinidad and Tobago been doing? We've been doing better, but not great. We are right at about 28.48% with about 15% fully vaccinated. We need to be really high. We need to be up here with the Canadians and the UK and even the Maldives and Seychelles, where they're reaching 70% of their population. We need to be down here where most of our population are immunized and to reduce the spread of the contagious disease, and we contain that. Right now, people are saying 99% of the deaths from COVID-19 are among the unvaccinated. It is really a pandemic of the unvaccinated. And even President Biden weighed in on it and said that, you know, there's a lot of issue with misinformation. The Vivek Murthy from the US said that how they're actually calling on social media companies to do more and combat the spread of these conspiracies and bring down this lack of control of this misinformation in the media, right? And they're saying that basically they're resulting in killing people because you're giving people the idea that the vaccines are unsafe and they could take their risks with COVID-19, and these people are dying at really great numbers. What can you risk? You can be exposed. You can get your immunocompromised elderly and children with no immunity exposed. You can serve as a pool and a reservoir, as other members of the panel have emphasized, to create these mutations that circulate, become more virulent, increase your risk of rate of these mutations. So we have to get vaccinated. We need to focus on the people who are highest risk, yes, but we need to get to that 70%. We are going to talk in these further sessions on the idea of mandatory vaccination, what happens with children, what happens with mental health, the impact on these people. But I want to leave you with this image. As vaccinations increased in the US between January and June 2021, cases and deaths came down drastically. It's a complete inverse correlation. So vaccines do work. We need to get to this point where the susceptible host is taken out of the picture to be able to end this pandemic. That is the only way. And I want to leave you with my final take home: get vaccinated, get vaccinated, get vaccinated. Thanks so very much.
Thank you very much indeed, Dr. Ramlachan, and thank you for that graphical representation in the chain of infection. And she, like the others before her, are endorsing vaccinations and are asking that we get those vaccination numbers up. Now comes the part that I know a lot of you all have been waiting on, and that's the question and answer segment. So first I'll ask Dr. Tilak Singh to open the batting for us. And here's a common question that we're hearing. You know, people get their vaccines, they say, you know, they're feeling a bit lethargic, they're feeling a bit of joint pains. And the question is, why would vaccines cause a side effect of muscle or joint pains? Is it owing to a constituent of the COVID-19 vaccine, or is it patient specific?
Thank you, Akash. And it's a very common problem following the administration of this vaccine, which goes into the muscle. And it's linked to an inflammatory response. And when you receive one of these COVID-19 jabs, it stimulates the soldiers or defenders in your body. So the antibodies would be primed and ready in case you were exposed in the future to somebody who had COVID-19, and these have a memory. These cells would be able to recognize exposure in the future to this particular virus, SARS-CoV-2. And these antibodies can sometimes cause an inflamed muscle. A sore arm is one of the common adverse effects. And we spoke about these inflammatory substances called cytokines, which can sometimes cause a cytokine storm in persons infected. However, these cytokines are part of a normal inflammatory response. So after you receive the vaccine, there are inflammatory substances which may account for the fever that follows. It's transient and would be expected to resolve after 24 to 48 hours with fluids, bed rest, and paracetamol. And similarly, that soreness or muscle inflammation is also transient and can be remedied with these mitigation strategies and would be expected to be temporary.
Thank you very much, Dr. Tilak Singh. Now, this question is for anyone, any member of the panel who thinks that they'll be able to answer it. It's a question from Daniel Francois. She's asking, what do studies say about effectiveness and risks of the vaccine with persons with HIV? Anyone on the panel?
I just mentioned that that was included in one of my many slides. They actually were included in the initial phase 3 trials for Pfizer, Moderna, AstraZeneca, and Johnson & Johnson, and they are recommended. They're part of one of the groups that's recommended for vaccination.
Okay, thank you very much. Another question that we're seeing is that I know, Dr. West, you would have touched on this before, but the person may have missed your part. Dr. West, they're asking, if I have a surgery coming up, should I take the vaccine or hold up for a bit?
So I did mention that. Thank you very much for the question and to the person asking it. So the various authorities around the world have issued guidelines. The Royal College of Surgeons have said roughly about a week. I would gather it, and others have said about 2 weeks. So somewhere between 1 to 2 weeks, you should hold off of having surgery if you've just had your vaccination. Or, as I said, on the other end, if you've had your surgery, you should probably wait 1 to 2 weeks before you have any further vaccinations. But it is not one fits all, because different types of surgery create different types of immunological responses. Cardiac surgery, where people go on a bypass machine, probably creates one of the most common large effects on the immune system. And for patients like that, we'd probably want to ask them to hold off a little longer until their physiology returns to normal. But lesser types of surgery, you could probably have your vaccine a little earlier, 1 to 2 weeks.
Thank you very much, Dr. West. Another question. They're asking, can people with varicose veins and vein-related problems be vaccinated? If yes, what are the precautions? And is there a preferred vaccine if someone has the aforementioned complications? This question coming in from Mindy Harry. And I don't know if one of our heart specialists, anyone would like to answer that. Dr. Thomas, maybe?
Sure. So varicose veins is a cardiovascular problem. And severe varicose veins, patients do have a risk of developing clots in those veins, a condition called DVT. If a patient has had a history of DVT, then if clots occur in the veins of the legs, those clots can dislodge and go to the lungs and cause what we call a pulmonary embolus. Therefore, patients who have had COVID, who are in hospital, are at an increased risk of having clots in their leg veins, and many of the doctors would use anticoagulation to prevent that from occurring. With the specific question as if a patient has varicose veins and they get the vaccine, should they be on anticoagulation regimen? There is no study that shows that that is necessary. So the answer to that is that if you have simple varicose veins, that is not an indication to take a prophylactic anticoagulant if you're going to have the vaccine.
Well, thank you very much, Dr. Thomas. This question has been directed for Professor Simangal, and the question is, what are the long-term effects of taking the vaccine with respect to fertility?
Yeah, that's of taking the vaccine. Okay, no known effects as far as I know. However, I will point out that because COVID is a virus, the virus that causes COVID rather, can get to any organ where the blood vessels go. There have been reports of adverse effects on male sexual responses where they have had COVID. So I don't know specifically about effects on women's reproductive health from COVID, but I wouldn't be surprised if there are adverse effects as well, because as I said, the virus causes what amounts to really be an inflammation of the blood vessels. So any organ supplied by the blood vessels will, of course, be at risk. The last part was, so I'm speaking of the effect of the virus, but the question was about the vaccine. And to answer again, I'm not aware of any effects of the vaccine. I don't know if any of the other panelists are on reproductive health of women. Thank you.
I could speak to that in terms of erectile dysfunction and reproductive health in women post-vaccination. That was studied very extensively, most of the WHO vaccines, and there are no known adverse effects. However, I would agree with Professor Timangal. Negative effects have been seen post-COVID-19 infection, both with male and female fertility, in that in the female's case, it can sometimes delay ovulation and have changes in menstruation and so on. And in the male case, cause erectile dysfunction. But these are not seen post-vaccination at all in any large enough numbers to be noted in any of the studies that I've read.
Thank you very much. Here's another question to any member of the panel who thinks they can answer it. The question from Mrs. Williams. Can someone with a brain tumor safely take the vaccine?
Well, I'll make a start on that. There are no reported effects, negative effects of taking the vaccine for people with specifically with brain tumors. And of course, somebody with a brain tumor has a general type of cancer and their immune system is reduced. And therefore, they are at risk of getting COVID-19. And therefore, it's a risk-benefit ratio. The effects of getting COVID-19 and the complications are far greater than any of the, in fact, there have been no known specific complications for vaccines when people have a brain tumor. So if that was the case, providing they were otherwise well, that patients should receive a vaccine.
Yes, that's right. I would agree with you, Mark. Cancer is a risk factor for worse outcomes with COVID. So whichever cancer you have, you should have the vaccine.
Yeah, and I would just need to point out here that the recommendations are to take it in between, when you're in remission or in between chemotherapy treatments in particular. That's the recommendations.
Yes, and if I can also add that with respect to brain tumors, that many of these patients, apart from conventional treatments by their specialists, such as radiotherapy or chemotherapy, may be on steroids too, and that further weakens immunity. And there is burgeoning evidence that persons with weaker levels of immunity may actually need booster shots in time to come, perhaps 6 months after that first set of vaccines.
I do want to add to Dr. Chilaxing, if you could mention lupus and those kinds of disorders as well too. Anybody with any kind of immunocompromised condition recommended that they be vaccinated, and I think they've been encouraged to take a booster if their immunity wanes because of the steroid usage. One thing that's important to note too is if you have an allergic response to the vaccine and you are treated with steroids, that will reduce your immunity, of course, that is acquired. And that's something to consider as well too, that you might actually need a booster of a different type of vaccine and so on afterwards.
Thank you very much. I'm sure Ms. Williams, is there someone who wanted to add something?
Yes, Akash, I was just saying too that for viewers and listeners, that should you be on a condition that requires long-term steroids, that if you are infected with COVID-19, you would want to have a chat with your doctor that doubling your steroids at that point would be imperative, because you can get very ill in someone who is on long-term steroids for a pre-existing medical problem in the throes of infection, surgery, trauma, or any sort of stress, they may need to increase their steroids at that point if infected with COVID.
Thank you very much. I'm sure Mrs. Williams really appreciated that. Another question, should patients who get seizures safely take the vaccine, or rather, can patients who get regular seizures safely take the vaccine?
I don't know who wants to Prof, you want to handle that one?
Well, again, the same issue arises. We haven't had epileptic seizures as a complication from the vaccine. In fact, the only contraindication to the vaccine, as I think Nicole said, or somebody said just now, is an allergic reaction to the vaccine. So yes, go ahead and take it. I am not seeing any reason to say that that is a contraindication at all.
Also medications, that's one of the things that a lot of people ask about. What, if they can take it if they're on certain medications, and there've been no except for the exception, I think, of warfarin. Dr. Thomas could speak to this, but there've been no real contraindications with normal diabetic medication, even chemotherapies, those kinds of things are recommended that they continue.
Right. As far as heart medicines are concerned, some people wonder about medications for high blood pressure, but the studies show that there is absolutely no reason to switch your hypertension medications if you have COVID or if you are going to take the vaccine. As far as the use of blood thinners and anticoagulants, they should be used as per the condition for which they have been indicated for. So generally speaking, one of the problems that could occur is if one were to stop certain heart medications and you lose the protective effect of those heart medications, and then we can see problems do occur. So the consensus is that there is no need to stop your heart medications because of the COVID illness or the vaccine.
Well, thank you very much for addressing anticoagulant drugs, Dr. Thomas. That was the next question I had. It's almost time for us to wrap up. I'm going to end with what I would call a loaded question, and good luck to anyone who wants to answer it. This question comes from Debbie Mahavir, and she's asking, how come as soon as they started vaccinations, there was a spike in cases?
Well, I think that's going to be me, right? The spike in cases, she means locally, she means worldwide. I don't know.
I think she means locally. I believe she means locally.
Okay, so if you look at the situation worldwide with vaccinations, you'll notice that in certain countries, when vaccinations started as early as, in some cases, Bahrain and so on, in October 2020, the numbers came down quite drastically because there were no variants in circulation. So the initial vaccination protocols were very successful in controlling those numbers. Same thing happened in the UK and the US. I showed you that slide where the vaccinations in the US look like this, right? In terms of deaths coming down with vaccinations increasing between January and June 2021, which is this year. What happened in Trinidad and Tobago, there was a big spike in May because of movements of people and so on, and opening up, I guess, a little bit in terms of people relaxing in Easter time and that kind of stuff. And that was literally because of spread, community spread. It really was the first time we had community spread at that level in Trinidad. And that really was not related to the presence of the vaccination, because you'd remember we got our first set of vaccinations way back in February 2021 from Mia Motley and Barbados as a donation. We got some more in March, we got some more in April. So we only really saw our increasing rate post-Easter. So you can't really say that there's a relation, even though people like to say that. There's no real correlation between the occurrence of the spike and the increasing numbers of vaccination. What we're seeing now in terms of vaccination, that's been, with the presence of the 800,000 Sinopharm, we are seeing our numbers approaching 15% fully vaccinated, which is higher than we've had in the past, but we're not actually seeing increases in cases that are correlating to that increase in vaccination. So there's really no correlation between that that we will be able to perceive in the world with increasing cases and increasing vaccination. In fact, it's the opposite.
Okay.
I do want to address something. Somebody asked about testing, and I didn't answer it. In terms of the testing that we referred to, the antigen, antibody, and RT-PCR are available locally at most labs. At Genix Diagnostics, we do all three, and there are quite a few labs around the country that do different ones. And again, if you have any concerns about what you need to do, just give us a call, give anybody a call, and I'm sure everybody would be able to assist and help and advise. You yourself might not determine the best test for you, and you probably need some advice. So it's probably best, especially if you're traveling to certain countries. Different airlines have different restrictions, different countries have different restrictions, especially the vaccination. We had this scene where somebody came from Canada to bury his mother and had to go back because he was told he had to quarantine. These are things that, you have to abide by the laws of the country in which you are entering and the country that you're leaving. We don't have control over that. And that's something that I want to emphasize. As the world becomes more and more vaccinated and we become more of an even playing field, this will become a lot easier to work. But right now with the vaccine passports and possibly with the mandatory vaccinations and these different countries having different approved vaccines, we're not going to be even right now. And we have to understand that.
I have a question, if you wouldn't mind, quickly. Sorry to hold people back. This is to Clifford. Thank you very much for your presentation, Clifford, and I enjoyed all of it, but particularly the part where you said that you were all vaccinated and your family were all vaccinated and you've never had any problem, which is great. But you did say that you had seen patients who were not vaccinated and you saw cardiac complications. Could you just, for the audience, say what those complications are? Because we are very pro-cardiac disease in this country.
So the complications I've seen in people who weren't vaccinated were first and foremost fulminant pneumonia, of which I've seen 2 deaths of people who have had a heart disease, but it was not a heart problem which caused their demise. They died from severe complications of the COVID. I have also seen patients who have had a myocarditis, and they present with a condition called heart failure, and they develop a shortness of breath, sometimes swelling of the legs. But the shortness of breath might not necessarily point to heart failure, because the shortness of breath also occurs in the pneumonia that occurs with the COVID illness. So you have to have a index of suspicion in picking up these things. There are, of all the COVID patients, some patients will have asymptomatic impairment of heart function from a myocarditis that is subclinical. But there are some cases where the myocarditis is fulminant and they end up with heart failure, cardiogenic shock, and even death. And finally, I have seen patients who have had a thrombotic event related to the COVID viral infection. The question that people ask is there a higher incidence of heart attacks during this COVID pandemic? And there have been conflicting thoughts. At some centers, people have seen a lower incidence of people coming in with heart attacks, but some of that may be related to the fact that people are more likely to wait and not go into hospital when they have symptoms of a heart attack. So, but there is an increased incidence of thrombosis and coronary events after COVID.
Thank you very much, Dr. Thomas. A really good question to end this discussion. Of course, Dr. Ramlachan would like me to add that 99.5% of people who are hospitalized and have severe disease or die are unvaccinated. 99.5% of people. Remember when we said we would cut off at 7:30 p.m.? Unfortunately, this is our cutoff point for this session. It's been a while since I've seen this much anticipation and excitement for one of these, but it's not often that we have a distinguished panel like this. And after listening and learning, it is quite obvious why this created such a buzz. I want to thank the University of Trinidad and Tobago for this ongoing series, much needed at this time. Thank you to our panelists. You all are the voices we need at this time, and we are made safer by your expertise. And thank you for everyone. Thank you to everyone who not only watched us live, but who also contributed with their questions. Of course, I expect much more to view this once the video is posted online. This is the first in a series of 4. So if you didn't get your questions answered today, there is another chance. There are 3 other chances actually. So we hope you stay with us throughout. This has been great. Keep following this UTT series for more evenings like this one. And take care, everyone.
Bye, everyone. Thank you.
Hi, everybody. Thank you, everybody. Good to see everybody as well.